Welcome to the symposium entitled The New Decade in Atherosclerotic Vascular Disease. I'm Professor Lale Tokgozoglu from Hacettepe University in Ankara, Turkey, and the distinguished faculty joining me today is Professor Chris Packard from Glasgow University in United Kingdom, Professor Stephen Nichols from Monash University, Melbourne, Australia, and Professor Kaushik Ray from Imperial College, London, United Kingdom. Here you can see the faculty's disclosures. The objectives of our symposium are to enhance our understanding of the unmet gaps and challenges in cardiovascular care. We need to assess the impact of risk factors in the development of plaque and cardiovascular outcomes in atherosclerotic vascular disease. We will be discussing what can be done to prevent atherosclerotic vascular disease and improve care with a focus on LDL cholesterol, and we will be discussing the importance of achieving guideline-specified LDL cholesterol goals. We will be starting our symposium with a discussion on the new horizons in cardiovascular disease management, including unmet needs, new opportunities, and a call to action. This will be followed by a discussion on the risk factors for atherosclerotic plaque development. And finally, we will allude to LDL cholesterol and cardiovascular outcomes in atherosclerotic vascular disease. So, I would like to start by asking Professor Packard, what is the disease burden of atherosclerotic vascular disease, the contribution of LDL cholesterol to this burden, and the trends in lipid-lowering therapy today?
My thanks to Lale for that kind introduction and for setting the scene in terms of the topic I've been asked to address, which is horizons in CVD management, the unmet need and the new opportunities to address novel treatments. This slide shows the burden of cardiovascular disease from a population perspective. In both middle, high and low-income countries, it is expected going forwards in terms of this report by the American College of Cardiology that coronary disease will continue to be a substantial burden in terms of number of deaths, as you can see here in the orange bars, and in terms of economic costs, particularly in low and middle income countries. The burden of disease is going to be in the trillions of dollars and account for about 50% of the disease burden economically. And in terms of healthcare costs, the projection forward by this report indicated that it would continue to be a burden for many years to come. How do we address this burden? By looking at the risk factors for coronary disease. And of these, the primary risk factor is LDL cholesterol. A combination of LDL is with cholesterol ester in the middle and ApoB around the surface. We can see from a historical perspective that this was identified in the 70s and 80s from epidemiology and pathology studies, and confirmed in monotherapy trials and combination therapy trials that lowered LDL and achieved a reduction in risk of coronary disease. This confirms the Hill criteria for causality. The genomics revolution in the 2010s identified that LDL was a cumulative risk factor across a life course and reinforced it as the primary target for therapy. But also remnants and Lp(a) were established as potential secondary factors, but we don't yet have therapies for them. The genomics revolution also identified potential new pathways for therapy by altering the expression of genes. What goals are we going to try and achieve in terms of LDL lowering? Well, over the 25-year history of the disease, of clinical trials, we can see that the starting LDL cholesterol went from about 4.5 millimoles per litre down to about 1.8 to 2 millimoles per litre. And the achieved level at the bottom of the arrow went from about 3 down to about 1 millimole per litre. Based on this guidelines were recommended goals of about 3 millimoles per litre down to 1.8 millimoles per litre in the 2011 and 2016 recommendations, and the European Society of Cardiology and EAS newest guidelines recommend a goal for very high-risk patients of about 1.4 millimoles per litre, and for those who've got the most aggressive form of the disease, down at 1 millimole per litre. So how are we doing in achieving these goals? Well, the recent European-wide Da Vinci study surveyed individuals who were being treated in clinical practice. You can see here that the majority of patients were on moderate intensity therapy in terms of statins. Next were those on high intensity therapy, and a small minority, were on combination therapy with ezetimibe or PCSK9 inhibitors. And a minority were achieving the goals, whether they be the 2016 or 2019 goals. Overall, in secondary prevention settings, 45% were achieving the 2016 AES goal of 1.8 millimoles per litre and 22% the 2019 goal of 1.4 millimoles per litre. Looking at individual patients from the outcome trials, the Fourier, Odyssey outcome and Improve It trials, looking at the placebo group where the LDLs were about 92 to 95 milligrams per deciliter, similar to the LDL seen in the Da Vinci survey. We can see here individuals at very high risk of further events. 4% annually is a risk of 1 in 5 having an ASCVD event in the next 5 years. And you can see the high risk of individuals who've had more than one prior MI, multivessel disease, or other major risk factors, such as a very high TIMI risk score. These are individuals who need further LDL lowering therapy in order to achieve the best possible outcome. How can this be achieved? Well, a rational approach is to combine therapy and to make combination LDL lowering the rule rather than the exception. We do this by adding to the enhancement of LDL receptor-mediated catabolism. This is the route that all of these drugs work by. Statins, ezetimibe, and bempedoic acid all reduce the cholesterol level in the liver, and that triggers an increase in LDL receptor catabolism. PCSK9 inhibitors and the small interfering RNA inclisiran reduce the amount of PCSK9 available to help degrade LDL receptors. So again, you're increasing LDL receptor-mediated catabolism in a meaningful way, and the combination can reduce LDL substantially. Here are the relative LDL reductions on these various treatments. Statins about 30 to greater than 50%, depending on the intensity of therapy. Ezetimibe, bempedoic acid, 18 to 19%, PCSK9 inhibitors about 60%, and inclisiran about 50%. Importantly, these LDL reductions are additive, and when you add them together, you get additive benefit, as shown in the combination therapy trials. The various therapeutic approaches now allow us to have different strategies for treatment. Oral agents can be given once daily, or you can use a PCSK9 monoclonal antibody to inject once or twice a month, or with inclisiran, inject about twice a year. These strategies may help us address intolerance and compliance issues, because in a recent survey, about 65% of mainly European clinicians reported intolerance or side effects as an issue, and about 28% identified non-adherence as a critical issue in their treatment of patients. So here we have the situation as it stands today. We have a concordance of evidence supporting LDL as the primary target for therapy. We know its link with risk is continuous, graded, and cumulative. There is no flaw to the benefit. The more you lower LDL, the more you lower risk, and there appears to be no treatment-emergent adverse events. There is a treatment gap that is significant, and combination therapy is the way to achieve that, to achieve our goals of addressing the treatment gap, particularly using the new therapeutic strategies that are available. Thank you for your attention.
Thank you, Professor Packard. My next question will be to Professor Nichols. What are the key risk factors involved in the development of plaques and the relationship between plaque development and atherosclerotic vascular disease risk?
Thank you, Lale. Thank you for the introduction. What I'd like to talk about is the relationship between cardiometabolic risk factors and the development and the progression of atherosclerotic plaque and its subsequent progression over time, because we know that the presence of disease and accelerated progression of the disease on a range of imaging modalities have been demonstrated to associate with a greater risk of cardiovascular events. Now, we know that atherosclerosis is a chronic disease. It doesn't just suddenly form at the time that a patient has their first clinically manifest event. Rather, we know the disease starts early in age, and over the course of many decades, it slowly and gradually accumulates within the walls of the artery. And that gives us enormous opportunity across the life course of the disease to be able to prevent, to be able to detect, and to be able to treat the disease. And as we've learned a lot more about the biology of atherosclerosis across its life course, we've also achieved a number of technological advances in arterial wall imaging. And these modalities enable, in both an invasive and a non-invasive perspective, for us to be able to image a range of vascular territories. We not only can see the disease, we can quantify the burden of the disease, we can detect its individual components, and with more recent advances in imaging, we can start to actually look at the functional implications of the disease. And that gives us a really important opportunity to be able to understand what are the relationships between both individual risk factors and combinations of risk factors in the natural history of disease progression, and potentially if we treat those risk factors, can we start to reverse that process? So the most important observation to date from these trials has been the importance of LDL cholesterol. We know the higher your LDL cholesterol level, the more progression of coronary atherosclerosis you will see. And in clinical trials of lipid-lowering therapies, we've seen a number of classes of agents slow the progression of the disease. And in fact, as you see on this slide, there is a direct relationship to the achieved level of LDL cholesterol and the ability to both slow disease progression and ultimately promote disease regression if you achieve an LDL cholesterol below 70 milligrams per deciliter or 1.8 millimoles per litre. However, not every patient that achieves such a low LDL cholesterol demonstrates disease regression. Here you see the factors associated with ongoing progression, and we observe ongoing progression in about 30% of patients who achieve an LDL less than 1.8. Who are those patients? They have diabetes, they have higher blood pressure, they have a lower HDL cholesterol, and they have a higher level of apolipoprotein B. And there are two important take-home messages of that observation. First of all, atherosclerosis is a multiple risk factor disease. So if you have other risk factors that are poorly controlled, you will still progress even if your LDL cholesterol looks okay. Secondly, ApoB tells us how many LDL particles you have. So LDL cholesterol can look okay, but if you still have too many individual LDL particles circulating in the blood, you still have an ongoing lipid risk of disease progression. And in fact, looking at the totality of these studies, we've really observed that risk factors very much associate with either accelerated or slowing of disease progression. We see accelerated plaque progression in patients with lots of small dense LDL, higher levels of triglyceride-rich lipoproteins, higher levels of lipoprotein A, higher levels of blood pressure, or patients with diabetes with poor levels of glycemic control. In contrast, we tend to see less progression or potentially regression in the setting of higher levels of HDL cholesterol or ApoA1, or in patients where we observe in the lab that they may have greater cholesterol efflux capacity. Now, on top of looking at this from a single risk factor perspective, what if we look at combining risk factors? And here's an analysis where you see disease progression in the coronary vasculature using intravascular ultrasound, patients stratified to having an LDL cholesterol above or below 70 mg per deciliter or 1.8 millimoles per litre, and a systolic blood pressure above or below 120 millimetres of mercury. The higher the blood pressure or the higher the level of LDL cholesterol, the more progression you see But what you also observe is the patients who have the highest levels of both LDL cholesterol and blood pressure have the most progression. The patients who have the lowest levels of both of those risk factors have the lowest degree of progression. And a group of patients in whom that's particularly important are patients with type 2 diabetes. Here you see an analysis of coronary imaging looking at disease progression in patients with type 2 diabetes according to the number of risk factors that are more aggressively treated. And you can see simply by controlling a greater number of risk factors, you see a gradual slowing of disease progression. In fact, you see regression of disease in the patients who are able to adequately control all their risk factors. So it's a multiple risk factor approach, which is going to be really important. Now, they are a lot of the risk factors that we kind of acquire over the life course. What about genetics and its potential impact on the artery wall? Now, we know from a genetic perspective that that can influence LDL cholesterol levels. And we know that looking at the Mendelian randomization studies, that the relationship between LDL cholesterol and cardiovascular risk is steeper in those studies than it is looking at cohort studies and randomized controlled trials. And we think that's because you're looking at a life course exposure of higher LDL cholesterol levels, given the genetic influence. What if we start to think of other ways that genetics may relate to the arterial wall and cardiovascular risk? This concept of polygenic risk scores that have emerged, the idea that we can calculate such a score for every individual patient. And we know that not only is a higher polygenic risk score associated with a higher likelihood of having cardiovascular events, but we see that here, you see that it associates with a higher calcium score, suggesting that there is a direct association with what's going on in the artery wall. Now, importantly, whether you have a higher polygenic risk score or a lower polygenic risk score, adopting a more favourable lifestyle in terms of diet and exercise was associated with a lower calcium score. We've seen exactly the same observations looking at cardiovascular risk. This would suggest that some modifiability that can still be observed even in the setting of a higher polygenic risk patient. Now, all of that has looked at burden and looked at disease progression. The whole other piece to this puzzle is to look within the plaque itself, to look at the composition of the plaque, and we know that there are a number of features that are consistent with plaque vulnerability, not only within the plaque itself, but the remodeling pattern of the artery wall. And so just like we've looked at the relationship between risk factors and their modification and disease burden, we are now going to start looking at their impact on plaque vulnerable features. And that will be an exciting kind of step for clinical trials moving forward. So to conclude, this is important because it really speaks to modifiability. Not only can imaging tell us a lot about those relationships, but it may be able to identify patients with more modifiable risk. Here you see two plaques. On the left, you see a fibrosed plaque. On the right, you see a lipid-rich inflamed plaque. It's the patient on the right with more modifiable plaque where we think there may be a bigger bang for the buck in terms of treating them, treating their risk factors, and it may be that imaging may triage us to the right patient moving forward. And that will be the next kind of step forward in clinical trials. I thank you for your attention.
Thank you, Professor Nichols. And my final question will be to Professor Ray. What are the limitations of lipid-lowering therapies in practice, and how can we do better to reduce cardiovascular outcomes in the population?
Thanks, Lale. That's a great question, and it's something that I'll cover and answer in this particular presentation. So if we look at the age at which cardiovascular disease occurs, the usual format of this is that atherosclerotic cardiovascular disease will occur in 50s, 60s, or later. And this is due to this interaction between genetic vulnerability that we are obviously born with and cumulative exposure to multiple risk factors. It's the cumulative element that we often forget about. So if you think about this, that we make diagnoses really quite late in life, and one of the disadvantages of that is that atherosclerosis is much more advanced, and what we forget is that we should actually be treating these people much more aggressively because the diagnosis is made late. Now, if we look at patients, this is data from Sweetheart, with a recent myocardial infarction, this is kind of further reinforced. So the average age of a myocardial infarction is in your 60s. If you look at the LDL cholesterol levels and the pre-treatment levels, well, we can see a couple of things. Firstly, 3/4 of patients are admitted without a prior being on statins previously. And when we optimize these treatments, then the LDL cholesterol levels with treatment varies between about 1.8 to about 2.3, which is nowhere near the current goals. Now, if we look at how we're practicing in Europe, and we can look at data from Da Vinci, and we can see in these patients at highest risk, those with established cardiovascular disease, we're essentially practicing statin-based monotherapy, and we're not using combination therapies. And the implication of that is that when our goals were actually easier to achieve, so LDLs below 1.8, 45% of patients on high-intensity statins would achieve goal, 54% on ezetimibe would achieve goal, and 67% with a MAB would achieve goal. But as soon as the goals moved to 1.4, then roughly 1 in 5 patients on high-intensity statins now achieving goal. And we're not using combination therapy properly. We're only using combination therapy in about 10% or so of our patients. Now, if we have to use combination therapy, the second problem that we have is, what about our patients? What about the burden of medications on our patients? And we can look at that in a little bit more detail. So if you look at the product of prescribing, for example, and the adherence of the patient, they track with LDL cholesterol reduction. So those people who adhere to statins properly, and when we prescribe statins properly, we can achieve significant reductions in LDL cholesterol. But because of this problem of underprescribing for those at highest risk and poor adherence, what we're seeing is at a population level, there may be at least 12,000 cases annually in the UK in people with ASCVD that are potentially preventable. So these are numbers that we could potentially optimize and reduce some of the population burden of cardiovascular disease. Now, so how might we do this? So I've told you that we need more combination therapy, and I've told you that small molecules may have challenges in terms of adherence. So if you look at how we can effectively reduce LDL cholesterol, the most efficient way of doing this is through the LDL receptor. So, and it's very simple. Make more of the LDL receptors, keep them alive for longer, and therefore provide sustainable reductions in LDL cholesterol, do it earlier and longer. Now, we can look at that in more detail here. So essentially, this is the hepatocyte. And we know that when we prescribe statins, what we do is we increase expression of the LDL receptor. Now, there's a second protein that's principally derived from the liver called PCSK9, which breaks down these LDL receptors or stops them being recycled back to the cell surface. Now, we can target this in one of two ways. We can target it at the level of the protein with monoclonal antibodies, but because we're targeting at the level of the protein, it basically means that we have to essentially inject these therapies every couple of weeks. An alternative step is that step between the protein and the signal for that, which is the gene. So this is targeting the message, and we can do this at the level of the messenger RNA in the cytoplasm with so-called sRNA-based therapies, which basically block translation of the signal for the protein and stop it being converted into the message. Now, that's great, but how are we going to implement this in clinical practice? Well, there are a couple of different options. One is investment and thinking about electronic health records and digital tools. So this was some work that we did in a population with established cardiovascular disease. So 250,000 patients with 45,000 events in a routine cohort in the UK. And you can see that the residual risk, despite optimizing treatment, if you like, is an annual event rate of 2.9%, so 10-year risk of 29%. And we can see that this tool, called the SMART tool, can actually predict events very accurately. So observed and predicted are almost identical. And you can see there's a whole distribution of risk in this patient population. So when a patient walks into your clinic and they're asymptomatic, it's a real struggle to work out who I should treat and what the benefits might be. So instead of thinking about just risk, we can move towards thinking about benefit. So if you look at this same cohort, and what we've done here is to basically look at the distribution of non-HDL and 10-year risk in this patient population. And then we've said, okay, let's imagine that we want to reduce residual risk in those that have the highest levels of lipids, but also the highest risk. So we can pick those people with 10-year risk above 20% and non-HDL levels above 2.6. And with a MAB, what we could do is reduce that non-HDL by around 50%. So we produce more people, or we push more people into the lower risk and the lower cholesterol profiles. And in the future, although that data was modeled with MABs, we know that these will need to be provided every couple of weeks. But in the future, we have therapeutic options with siRNA-based therapies, whereby essentially a treatment like inclisiran on day 1, day 90, and 6 monthly thereafter can produce sustained time average reductions in LDL of over 50%. And that's a huge advantage for population health, because essentially nature doesn't care how you lower LDL cholesterol levels. You can do it with 365 pills a year, with 26 injections a year with MABs, with 2 injections a year with siRNA. What you're overcoming is adherence. So effectively, you're changing the area under the curve. You're changing population level exposure to LDL cholesterol. And if you look at cumulative benefits and you project this over 50 years rather than in 5 years, as we do in most trials, this should translate into significant benefit. So imagine a time where we identify these patients and we can essentially provide population level coverage in the same way that we can improve pollution. We can change the distribution of health in our populations. Thank you for listening.
Thank you, Professor Ray. So in this session, we have considered the unmet gaps and challenges in cardiovascular care. We've discussed the impact of risk factors in the development of the plaque and cardiovascular outcomes. We have discussed what can be done to prevent atherosclerotic vascular disease and improve care, focusing on LDL cholesterol, and the importance of achieving guidelines-specified LDL cholesterol goals. I would like to finish by saying that today we have a better understanding of the role of LDL cholesterol in atherosclerotic vascular disease development and new avenues for LDL cholesterol management. However, the implementation of these tools in practice has lagged significantly. We should not miss the opportunity to achieve guideline-recommended LDL cholesterol goals to prevent atherosclerotic vascular disease in our patients. Thank you for joining us.